Ocular Genetics. Our speaker today truly needs no introduction. She's the most common face of this group. So many of you recently attended the Concord 2 meeting where it was it was focused on ocular genetics, and we discussed a lot of topics and we heard from a lot of specialists and we learned a lot of things. So in continuation of that learning, today ma'am will be speaking about a very difficult situation that we encounter in our clinics, which is how to handle the negative report when the phenotype is quite clear. So Dr. Shailja is a senior consultant at Dr. Shroff Charity Eye Hospital, specializing in pediatric ophthalmology, strabismus, and neuro-ophthalmology. She leads the hospital's ocular genetic services and has extensive expertise in inherited eye disorders, rare genetic diseases, and the integration of genetic diagnostics into ophthalmic care. She is trained in genetics and genomics at the NIH USA. Dr. Shailja has contributed significantly to research, clinical care, and in the field of ocular genetics. So today she'll be speaking about the negative report, its limitations, interpretation, and the next steps. Over to you, ma'am.
Thank you, Nivedita, for that kind introduction. So, as Nivedita introduced, thank you again for the introduction. And I would be speaking about how to tackle negative report. This is very often, found in our clinical settings, that we have a very high clinical suspicion of a genetic disorder, and we very excitedly send a genetic test, and it comes out to be negative. We counsel the patients regarding what is the use of the genetic test, that it will confirm the diagnosis or it will help in family planning. And when you land up with a negative report, all that just breaks your heart, and even the patient, they feel that they are back to square one and nothing is kind of progressing in the diagnostic odyssey. So I will first take you through some cases where there was a negative report and what was done, and then probably discuss about why there are negative reports and how to tackle them as a whole. So this 1-year-old boy, he presented to us with bilateral congenital aniridia. This was a classical phenotype where the iris was nearly totally absent, and there was a foveal hypoplasia. There was minimal, limbal stem cell deficiency at this age, and it was bilateral. And but this was not having a family history, so it was a sporadic aniridia. And we all know that in sporadic aniridia, there is a 20 to 30% risk of having a contiguous Wilms tumor 1, which is a WT1 gene deletion. And when there is a WT1 gene deletion, there is a 50% risk of developing Wilms tumor, which is a very aggressive tumor of the kidneys. So, in the absence of a genetic test confirmation, you need a 3 to 6 monthly surveillance with ultrasound of the kidney ureter bladder till 8 years of age. So it makes sense to confirm a WT1 deletion or rule out a WT1 deletion whenever a sporadic aniridia is encountered. So taking that into mind, we ordered the whole exome test of this patient, and again, to our disbelief, we got a negative report. Now, is it really disheartening? Did everything all right here? Why is this negative report? Is it really significant? You also see that it says negative in the genes for aniridia. At the same time, they said no clinical significant copy number variations. Copy number variations usually are like deletions, duplications. And as mentioned in the previous slide, we were looking for a deletion of the WT1 gene along with the PAC6 gene. So these were all negative in this whole exome sequencing. Nowadays, a whole exome sequencing can detect some of the copy number variations, and that is why we thought we'll order the whole exome test. But yes, this came out to be negative. Now what do you do? What do you tell the patient that you have invested, or you have paid for this test and it is still negative? So do you accept this negative test? As clinicians, we all know that aniridia is a genetic disorder. There has to be some defect in the gene, in somewhere in the genetic code of this patient, to lead to this disorder. But why is this test coming negative? So, if we see the genetics of aniridia, the primary genetic causes could be PAX6 gene mutations. Now, in this, the particular gene, the PAX6 gene, it may have missense variations, nonsense variation. It can have, small fucodons, deletions, or duplications. It can have frame shift mutations. These are all point mutations which can happen, or deletions and rearrangement, as mentioned in the second. Or it could be a large deletion which can include both the PAX6 and WT1. For this patient, we really wanted to know that large deletion, which is PAX6, which is encompassing both PAX6 and WT1. While the whole exome sequencing or the next generation sequencing, PAX6 sequencing, and even panels, they are good for point mutations and even small deletions and duplications. However, they are not very good for larger deletions and duplications or rearrangements, for which a chromosomal microarray or even a whole genome sequencing is required. So, first and foremost, if you get a negative test, what this example tells us is that that's not the end of it. You need to question the testing strategy that you have used, and maybe for this particular patient, a different strategy may be required. Coming to the next case. Now, this is a 32-year-old male with a gradual progressive diminution of vision since 6 years of age. And he had, this was bilateral and simultaneous. There was no photophobia, no nystagmus, no nyctalopia. This is his best corrected vision, which is 6 by 36 in both the eyes. He also had, yeah, a very significant loss of contrast sensitivity and a color vision deficit. Refraction was not very significant, and based on the on the examination, he was found to have bilateral temporal pallor. So these are his disc photographs showing the bilateral temporal pallor. Visual fields and OCT were done, and visual field showed central scotoma. So, and OCT showed GCC loss. So, based on a temporal disc pallor, central scotoma, and GCC loss, these were the differential diagnosis. Nutritional optic neuropathy, which was ruled out. Vitamin B12 and folic acid were done. They were a little bit low, but vitamins were prescribed. But this would not really lead to a chronic progressive, loss of vision as he was suggesting. Toxic optic neuropathy could be one of the cause, but there were no risk factors identified. He did not have any substance abuse, or he did not take any chronic intake of any drugs was there. Hereditary optic neuropathy definitely came into picture, and we were thinking about LH1, autosomal recessive, autosomal dominant, all types of hereditary optic neuropathies here. Compressive optic neuropathy also, whenever there's a gradual progression of vision loss. Yes, the fields did not really tell that this could be, or did not really were respecting midline, but still a CMRI was done and it came to be normal. So we were left with the hereditary optic neuropathy, and on questioning the in the pedigree, we came to find out that one of the younger brothers was also affected. One of the elder brother, I think, was affected with the similar kind of disorder, where there was a loss of vision, or a gradual progressive loss of vision since childhood. So, looking at two males and having a diagnosis of a hereditary optic neuropathy, what comes to your mind is Leber's hereditary optic neuropathy, because it's the most common type of optic neuropathy and affecting more males, although it is mitochondrial inheritance, but yet due to some other reasons it is more common in males. So first thing we did was test him for a LH1 known mutations, and this test kind of tested the most common four mutations of LH1, and they came out to be normal. Again, a negative report, but you have a very high clinical suspicion. What do you do? So again, questioning, did we order the right test? What is it that we are missing? But before again going and telling him do this, do that, what we really missed doing in the first case was, the first instance was that we didn't had the chance to examine the younger brother. So again, the question, do you accept this negative test? As I mentioned, you have a family history, similar kind of a problem which is there. It has to be a genetic disorder. Why didn't we get it hit? Okay, so what are we doing wrong? So the younger brother was then called to be examined. uh, he also had a progressive loss of vision in both these, and these are outstation patients. This time the younger brother came, but the elder one did not come, and he had this vision similar, again a temporal pallor, but there was also an RP atrophy at the macula, and old records were suggesting of cone rod dystrophy. So this totally changes the perspective totally changes what we are looking at. So we revisited the photographs of our own patient, and what we could see, yes, there was something abnormal in the fovea, but on a cursory look, if you see it, the pallor is more striking and rest of the retina looks normal, but there was definitely something abnormal going on around the fovea here. So we look back at the other reports. We saw, yes, the ganglion cell analysis showed that there is GCC thinning, but even the other layers of the retina were thin, which is very unusual in a optic neuropathy or a hereditary optic neuropathy. And what else is unusual is that having a normal RNFL. So the retinal nerve fiber layer thickness was normal, yet the GCC were normal or thin. The fovea was thin, so it's not really optic neuropathy or a ganglion cell problem here, but it's more of the other layers of the retina. And a high definition OCT actually showed, you can see this ISOS junction and the photoreceptor layer coming and just ending here near the fovea, and there's foveal thinning on both the sides, it's ending. So the diagnosis here changed, and this is the autofluorescence which just gives away the diagnosis. It's actually a cone dystrophy or cone rod dystrophy. So of course, a mitochondrial gene, or especially targeting a LH1, will not detect it. We ordered a clinical exome at that time, whole exome sequencing. This is an old patient. Whole exome sequencing was not so cheap, and it was expensive. Patient opted for a clinical exome, and even here we did find something related to the retinal dystrophy, but it did not explain the patient's phenotype. And also it is autosomal recessive and heterozygous, so we still don't have answer for this patient yet. We were planning to get a reanalysis done for him now after all these years, or maybe even go for a whole exome. But what I wanted to highlight with this case is that if you get a negative report, well, like the first test, you have to like the first case, first check your testing strategy, and the second, relook at the phenotype. Maybe your phenotype is not really perfect, and you have directed a wrong test, or when you request for the test to the lab, they will look for the specific phenotype that you have ordered or you have mentioned in the TRF, the requisition form. So if you have mentioned wrong, then they would be looking in the wrong direction. So your phenotyping has to be perfect, and for that you keep revisiting your patient. There might be some new phenotype, a new form, new characteristics may be added, and those, if you add to the report, you may get a better outcome from the genetic test. Coming to this third case, again kind of connects the two cases. This is an 18-year-old boy with a short height and a microspherophakia. He also had a secondary angle closure glaucoma. So we were thinking about of Weil-Marchesani syndrome. However, when we did this test, again, no pathogenic or likely pathogenic for the reported phenotype were detected. So same thing, what do we check? We check what test was ordered here. So do you accept this negative test? No, we'll go back and check everything. So what test was ordered here was a ophthalmic panel. Now, what is an ophthalmic panel? It contains some genes, maybe around 200, 300, 500, depending on your lab, but it does not contain everything. Now, we looked back at the panel and we saw whether Weil-Marchesani, all the types of genes which are related to it are covered. It did cover the Adams 10, which is the most common one, but it did not cover other ones, and that is what we got after whole exome sequencing. So this is just showing a diagram showing how the different panel they look at our genome. So if the entire disk is our genome, which is checked by the whole genome sequencing, which sequences 100% of the DNA, including the coding introns, the non-coding the coding regions, the non-coding regions. It also detects the structural variants, and it also connects the covers the mitochondrial genome. Whereas whole exome sequencing, it just covers 1 to 2% of the total genome, but it covers all of the protein coding regions. So majority of your patients will get a result when you do whole exome sequencing, but many of times you may miss it because the mutations may be in the non-coding regions, or they may be structural variants, like shown in the previous examples. And panels are even more concentrated just a few genes selected to the phenotype. So if you are selecting a panel test, you better be very sure of your phenotype and then select the panel test. Otherwise, if you miss it, then you may go wrong, and every time you order a test, the patient has to pay again. So in this patient, when the whole exome sequencing was done, then you can see that it came out to be ADAM 17, which is type 4 Wilmar-Chassani. It is not very common, and that is why it was not covered in that panel test. So you relook at the test again. That is what I wanted to highlight. Now coming to this case. Now this is a very intriguing example. This family is a family of bilateral retinoblastoma. The father is affected here. This is his phenotype. The one of the two both the daughters are affected. Okay, this is the first daughter's phenotype, this is second daughter. And the main thing for getting this genetic testing done was actually prenatal diagnosis, because they didn't want another child. They really were desperate for a normal child who would kind of take care of all of them. So we know that retinoblastoma could be bilateral or unilateral. And the bilateral retinoblastoma is the one which is heritable. So it has to be present in the germline, right? That means it will present in all the cells, and it will be easily detectable in the blood. Tumor usually develops both in both the eyes, and the family members are at 50% of recurrence risk is there. Whereas unilateral retinoblastoma, it is somatic. It will be present only in the retinal cells, so you may not get it in the blood. 15% of heritable retinoblastoma may be unilateral, so you may get it in the blood. But if it's a purely unilateral or sporadic retinoblastoma, then the risk to siblings is just 1%. So looking at this, we think that this patient, if we order a genetic test, especially the RB1, and 95% of retinoblastomas are because of RB1 mutations. So we got a RB1 gene analysis. The sibling 1 came to be negative. Sibling 2 came to be negative. And now we were thinking, what is it? Both the siblings are negative. What to be done? Is it really, we are looking at some other thing? What is happening? This is a heritable retinoblastoma. It has to come positive. So we thought maybe it's a deletion duplication, which is missed by RB1 gene sequencing. So we ordered for an MLPA, which is RB1 gene deletion duplication analysis, and surprisingly, that was also negative. We sent the patient's sample for reanalysis. Asking the lab, please check it again. It has to have some variation, because it's a heritable retinoblastoma. It's a bilateral retinoblastoma, and then it was also negative. So what is it that we are missing? Do you accept this negative test? That's my question again. It is a very clear cut case of a heritable retinoblastoma, multiple family members affected, and they are depending on us for a prenatal diagnosis of their next child. So now look, coming to, before I tell you what we did in this case and how we kind of answered the question, I just want you to look at the types of reports that can come out of a genetic test. The clear cut ones are the positive ones, which are pathogenic or likely pathogenic as per the ACMG criteria. There could be sometimes indeterminate variants. That means you have variants, but there could be a technical artifact. For example, a test which detects something like a WS telling you about a copy number variant, but you really need to do a MLP or a CMA to confirm that deletion or duplication. So this is like an indeterminate variant. VUS, we all know that this is you get a hit, you get a variant, but there is not there, you don't have sufficient evidence to say that this is pathogenic, and it may be pathogenic, but you really don't have that evidence right now. So these three things are quite clear. But in negative, there are actually two types of negative. One is an uninformative negative, and one is a true negative. Now, when a patient with a clinical diagnosis or a very strong family history tests negative, if it is negative for that particular variant which is present in the family and it has been detected in the family, and you do a specific test for it and you detect it to be negative, only then you can say that it's true negative. Whereas if there is no prior genetic testing in the family, but there is a family history and you get a negative, it is an uninformative negative. Now, to explain this, for example, if somebody has a history of a breast cancer in the family, okay, and just that person wants to know whether he whether she carries the risk. So it goes to a lab and asks them to screen for a BRCA1 and if it comes negative, you really can't say that it's really negative, because there, because of so many factors and so many things that we discussed. Okay, there could be a variant in that patient which is really not reported. There could be a variant which is intronic variant or something which is not detected by that testing strategy. So giving out that negative report would really be wrong, because because you may be, it may be a false negative. So that is called an uninformative negative. Okay, but a true negative is, for example, the person who has a family history, and family member who is affected by BRCA1 has got it tested. You know that exact BRCA1 mutation, and you check for that exact BRCA1 mutation in this particular patient, and or this person seeking genetic testing or a genetic counseling, and you found that to be negative, and that is what is a true negative. For example, this patient with aniridia, where we know that this is the mutation in this person, and then you check the maternal uncle who is unaffected, and you get that same mutation negative. This is a true negative. Okay, if the maternal uncle just walks in and gets himself tested without knowing what was there in the proband, and he gets negative, then that is not a true negative. That is a undeterminate, or it's a uninformative negative. So a true negative is that when you detect that same mutation, when you fail to detect that same mutation which is there in the patient. For example, here if you see, there is a D missing in the friend letter here, and you read the patient's the relatives report, and you see that the D is present there, which is normal. So only then you can say that it's a true negative. So what we going back to a retinoblastoma case, where there was a family history, multiple family members affected, we were repeatedly getting our WS, our RB1 sequencing negative, MLPA negative, and finally a whole genome sequencing was done in that patient, and an intronic variant was found, and which was likely pathogenic. So that is how ultimately the loop was closed with a whole genome sequencing this patient. So finding a genetic variant is not simple. It depends upon lots of things. It depends upon how well the library is made. Library is basically, you before you put the DNA into a sequencer, you adapt it to in a way that the sequencer is able to read it. So if the library preparation has something, has a problem, that a very basic step at that very basic step, that also can affect the yield of your genetic test. It depends upon the type of test applied, whether it is appropriate for your phenotype. It depends upon the depth of coverage. That means whether the test is able to say that particular gene has been covered adequately, and number of reads that have gone through it, and so that nothing is missed. The pipelines which are used, the pipelines, by pipelines I mean that once you get the output from the sequencer, then what all is used to filter out which variants would be affected, or which variants are important for your particular patient, sample quality as we discussed, and also the phenotype that you described. So there are a lot many things that determine the yield of your genetic test. And we know that whole exome sequencing is most commonly employed. It covers the protein coding region, but it does not cover the non-protein coding regions. It does not cover the mitochondrial, unless the test specifically covers both the, nuclear as well as mitochondrial genes. It does not detect repeat expansions. It does not detect, copy number variants, or deletion duplications adequately as of now. And whole exome sequencing although covers all of these, but it is very expensive as of now. But incorporating whole exome sequencing, or doing it sequentially after WS, can increase the yield of your genetic test overall. This is again, I don't know why my animation is not working here in this slide. So this is again a patient where RB1 sequencing was negative, and I wanted to highlight the date here. So in March, first RB1 gene sequencing was done, then methylation, again deletion duplication, both negative. In this patient, we didn't do a genome or a whole genome sequencing, but we, after some time, because in this patient there was no hurry to for prenatal testing, but after almost 6 months, um, the patient what do you call sample was reanalyzed, sent for reanalysis to the lab, and this time they found it. So what is reanalysis is that, many a times some of these new literature keeps on adding up, and what the lab thinks to be VUS or does not seem to be pathogenic and does not report it, after some time, due to this evolution in the knowledge or the literature that we know, some of the new variants may be detected as pathogenic and may be reported. So many times reanalysis average time is usually recommended time is around a year, where you should reanalyze your negative samples. You send the lab for reanalysis, and may kind of help. The last concept that I want to touch is the concept of mosaicism. Now, what is mosaicism? Mosaicism is a phenomenon in which a defect in the a genetic defect occurs after uh, the fertilization. Okay, so when there are few cells, the embryo is a few cell stage. One of the cells has the mutation, and now all the derivatives of that cell will have that variant, a variation of that DNA, but the rest of the DNA would be normal. A very apt example of it is tumors. The tumors in tumors, the DNA repair mechanism or DNA variations have occur in a particular cell of the body or particular organ of the body. So in that, you have to test that tissue if you really want a positive answer or a positive report. If you test some other tissue, you may get a negative report. So that happens in in retinoblastoma, unilateral retinoblastoma, where you really want to know the genetic mutation. You have to send the tissue sample, and blood will not find it. So you need to know what all can happen if a particular disease is known to have mosaicism, or if you're dealing with tumors. And if you have tumor tissue, then best to check that particular tissue. So what we really know is that there is lot many things in genetic testing. What we know is really the tip of the iceberg. There could be undiscovered genes which are lying under the surface. There are technical blind spots. Also, some of the diseases can be polygenic or have multifactorial risk factors in which your simple sequencing will not be able to detect the cause of the disease. So you have to have the right tissue, you have to have the right tech, knowing the limitations of each of these tests and what test to apply for which kind of disease, and also the right timing. So a negative test does not mean absence of a genetic disease. Genetic tests are not like x-rays. That means if there is a fracture, you will see it. No, it's not like that. In case of doubt, you always believe on the clinical suspicion. It has to prevail, and you counsel the patients accordingly. But you can go back and revisit your phenotype, revisit your testing strategy, revisit the analysis again. So all these things can help you get a better result. So to summarize, all these things which are mentioned on the left can lead to a negative report. The limitations of testing technology, incomplete knowledge that we have, variant interpretation challenges, it could be genotype phenotype mismatch, testing strategy limitations, and sample related issues. But on the right, what you see is that what all you can do. First and foremost, reevaluate your clinical diagnosis, revisit the genetic test performed. If you have existing raw data, go and reanalyze the raw data, ask the labs to reanalyze it, and in light of any new findings that you have, or otherwise also consider additional tests or complementary tests. Like for example, if you have done a whole exome, you think it's a deletion duplication, go ahead with chromosomal microarray. Test the right tissue that will need an understanding of the biology of the disease. You can have family based testing. Either multiple family members affected, if one gets negative, you can test in other family members, you can test in the non affected people and affected people to get a idea of what is happening in the family. Sometimes you have to consider non Mendelian mechanisms like multifactorial etiology. It's good to have multidisciplinary review, involve your labs, involve the bioinformaticians, have another person take a look at the patient. Maybe you are missing something in the phenotype, that the other person will pick it up. Maybe refer to a medical geneticist who can pick up some other non-ophthalmological findings which may help in your diagnosis. Sometimes you have to just end up enrolling them for research purposes because you are not really getting a diagnosis. and of course longitudinal follow-up of your patients, because new findings can keep adding on to these genetic disorders. This is just an information about the World Society of Pediatric Ophthalmology and Strabismus. They have very good genetic sessions. That is why I've put it here. And subspecialty day at the in London on September in the ESCRS meeting, and the main meeting is WSPS 6. It's in Cancun, Mexico, next year in May. Thanks to all my mentors, patients, and the team of Center for Unknown and Rare Eye Diseases here at Shroff. Thank you everyone for your patient listening, and now we are open for questions.
Hello, Shailja.
Hello.
I'm Annie Hassan here.
Hello, ma'am.
Yeah, lovely, lovely. You presented it so clearly and nicely. But I
Thank
had
you, ma'am.
one patient, and that has really, like they say in cricket, stumped me. The family had a, history of breast and ovarian cancer, five
Okay.
brothers and sisters, two
Mm-hmm.
with breast cancer, one with ovarian cancer. I
Okay.
hadn't seen them, but they had
Mm-hmm.
come from Delhi. I had got the pedigrees, got their sample collected, BRCA testing done. The
Mm-hmm.
first index case, the elder sister, had a specific variant. The other sister with breast cancer did not have that. The one with ovarian had that. And I was really wondering, what am I getting into? Because what has three of the same family,
Mm-hmm.
one with ovarian, two with breast, the two breast cancers, and the brother wanted to know if he's carrying it because he had two daughters.
Okay.
Now, what do I do for the brother? Do I just ask for BRCA panel? And so I went back. You are clinicians, you all go back to the clinical phenotype. I went back to the pedigree and I
Mm-hmm.
said, let me see where this thing is coming from. So got
Mm-hmm.
more details of the paternal side of the family because the maternal, it was seeing, it was very clear that mother had a breast cancer. She died very early. Then these were the five children. Looked at the father's paternal side, and then there also I found other cancers. And then I went back and did a larger germline testing.
Mm-hmm.
Not because then it looked like just BRCA1, BRCA2. So, like you said, I had to revisit the pedigree and then revisit the type of test which we had offered. And we were very happy that we have done it, just BRCA1, BRCA2, blah.
Yeah.
And then we got the other gene, which was, and so for the brother, we had to do both the variants and then plan to do it in his daughters.
Mm. So that's a
But
great
you are right,
point.
this is a
That
negative
going
test
back
when
to
you
the
are.
pedigree, I don't think so. We had any case like that. So, or maybe we never thought of, revisiting the pedigree. Of course, the patient with the optic neuropathy also, actually, the pedigree clinched the diagnosis that there is another family member which is affected, the brother. And when we saw the brother, we actually thought that then that's when we realized that we are missing something in the proband. So yes, definitely revisiting the pedigree and looking at the available family members. Actually, this should be done as a first step. And whenever a patient comes with a genetic disorder, whichever is the family member who is available, then and there should be examined and examined like in toto. Like if it's a retinal problem, dilate those patients and examine cataract, dilate those patients and examine those family members and examine them. Only then you can say whether they have really have the disease, yes or no. Just by history it should never be said that it's yes or no. That's very important. So thank you, ma'am, for highlighting this case. So we'll remember
And
to
you
revisit the
presented
pedigree again.
wonderfully. Thank you, Shailaja.
Oh, thank you, ma'am. Thank you so much.
Dr. Shailaja, this is Dr. Rupa.
Hello, Dr. Rupa. How
Excellent.
are you?
Yeah, I'm fine. Excellent presentation, Dr. Shailaja. It's really nice. Because we find so many times like these kind of situations. I have had
Yeah.
many patients with LCA. We know that it's a typical LCA patient, but still we are not getting this one genetic
Yes.
mutation. And
Yeah.
we have sent for whole exome sequencing itself.
Mm-hmm.
So, as you said, we have not sent for reanalysis yet. I think that
Yes.
1 year, once it goes away, it's good. But my question is, when the first child is affected like this,
Yep.
so we have to give a genetic counseling, no? That
Mm-hmm.
becomes a hectic thing for us. How do we counsel those parents? Like when you get with the whole exome sequencing, we don't get a positive mutation. How do we go about it, such
Mm-hmm.
patients? I think it's
Yeah,
quite
that's
difficult situation. I feel because should we ask them for a prenatal diagnosis if they want to go for a second baby or something?
Actually, that's not
Hmm.
recommended. It is not even allowed that
Yeah.
if you don't have the genetic variation, a known genetic variation in the family that you
Yeah.
are looking for in that particular fetus, that you
Okay.
go ahead with a testing. It
Hmm.
is not recommended. It's not allowed.
Not allowed. Okay.
Maybe Dr. Annie ma'am can actually highlight and add more to it.
Yeah. The Dr. Rupa, what
Yes.
we suggest
Yeah.
is, most of the time,
Hmm.
the what to expect from it comes in the pre-test counseling.
Mm,
Okay.
We tell them that if you are coming for a prenatal, I always ask, are you
Hmm.
planning another baby? Are you already pregnant? Because
Okay.
the whole
mm,
counseling changes with the situation.
Okay.
And like Shailaja said, unless
Hmm.
we have a handle, we are
Hmm.
not
mm,
supposed to offer them
Okay.
invasive testing.
Right.
So we
Right.
have to tell them that, okay, can you wait? Is it okay? It's four
Yeah.
weeks. So do we have time to do this test?
Yeah.
And in those cases, reanalysis, we don't wait for a year.
Yeah.
We
mm,
just
Okay.
yeah.
go to the lab and say, "Okay, this family is
Yeah.
waiting for prenatal
Right.
testing. So we
Sure.
need your help immediately."
So
So that
okay.
will
Okay.
help you.
Sure. Sure. Okay. Yeah. That's a very nice idea. Right. Okay. Thank you so much. Thank you, Dr. Shalija. It's a wonderful. This one.
Thank you. I also had very, I mean, kind of enlightenment when I read about all these things.
Yeah. Right. That's true. When you make a presentation,
Otherwise, we don't read
right.
all these things unless we have
Right.
to
Right. Yeah.
present or
Correct. Yeah. That's what. That's true. Thank you.
any other questions. If not, then maybe we can call it a day and, end this earlier than usual. Nivedita, you want to add something?
Shailaja,
Maitri?
Shailja.
just a
Yes, ma'am.
thought. Uh, does it help? Because every lab has a different pipeline. Have
Yeah.
you had the experience of sending the same case to some other lab and got something else?
Yeah, that's a very good question, ma'am. And we have done this. In fact, we had our doubts, especially again with our retinoblastoma patients, and thinking that, why is we are not getting, maybe the lab is not having the right pipeline or things. And we have done it for other diseases as well. If I remember, I think we have done it mainly for 7, 8 times probably, and once we got a good different report in one other patient, another for one particular patient from one lab. Most of the time, we didn't find a really positive hit or a relevant hit. They have given us some other new variants, which again were VUS or didn't really solve the puzzle. So far we haven't had that, but we have done that. We have done that. I've done it for my MAC patients. I've done it for our retinoblastoma. We have done it, I think, a couple of other patients where we were very sure. I remember a patient, and I quote this patient many times because the patient's parents were very much keen for a genetic diagnosis. This was a CHED patient. I mean, clinically looking as a CHED and got a VUS. and a heterozygous mutation for an autosomal recessive disease, but in the SLC411 gene. So that patient, I think I sent it to several people. In fact, I've sent the raw data abroad also to some of my collaborators to just analyze and see if there is a second hit which is there, which you are missing. So we have done all these. Sometimes we do get, but I would not say it's very frequently that we get a better result if we just send it to another lab.
Um, Dr. Shailja, can I ask a question? This is Dr. Tulika here.
Yeah, Dr. Tulika, please ask. Go ahead.
So I was talking about these three brothers. All three of them have a peculiar cataract. It's almost like I've operated all three of them. It was
Uh-huh.
more like a posterior lentiglobus, not even a conus.
Okay.
And all of them had shown themselves. So one of the kids, the proband, the first kid I saw, also has nephrolithiasis, has Peters anomaly, and I've been seeing him since he was born because he was sent to me with the corneal opacity in the periphery, and he
Okay.
developed a cataract later on, perhaps around 1.5 years of age. His brothers came to me after that because then they were genetically tested and then they were sent and then they were also found to have cataract. Now, two of these brothers, they had this homozygous ADMTS9 variant, which was
Adams.
present. Yeah, Adams 9.
Adams
And
9.
yeah,
Okay.
and the third, the oldest brother, who is also autistic, he did not have either homozygous or heterozygous, any of these. The parents are consanguineous, so this is an autosomal recessive disorder. Um, but this is all that we found. And the geneticist is doing more tests. I mean, she's going to check the parents and stuff like that. I don't know what's happening here, but she's also written nephronolithiasis, related
Nephronophthisis.
ciliopathy, phthisis, yeah, related ciliopathy by gene
Yes.
mutation analysis.
So this
This is
Adams 9
homozygous.
was a pathogenic variant?
So this is the problem. I told you she did not share the whole report with me, but she's
Okay.
written this in the clinical notes. So I work in a tertiary care center where all the specialties are there. So
Yeah.
this uh, this is a geneticist and a metabologist who works up on these patients, and the reports are never revealed on the on the actual
Okay.
software. They come as printouts and they're only shared with certain people. So I have
Okay.
been asking her for the actual thing, but this is what she has put in the clinical notes, and
Okay.
she's still working on it, and I don't know what's the way forward. Or I did not find any. The Is the Adams 9 gene ever related to cataract? Because I did not find it with posterior lenticonus, and these are bilateral. These are
Mm-hmm.
bilateral posterior lentiglobus, so they are, they have a genetic association. Normally, unilaterals don't have.
Mm-hmm. So,
So,
what I can
what's
think
the
of
way
is that,
forward?
so Adams 9, see, I was just also Googling as you were speaking, because I mean these
Yeah,
things are so vast you can't really remember everything.
yeah,
But Adams 9, yes, has been reported with nephronophthisis, and
thesis.
is a ciliopathy and Joubert syndrome
Mm,
and other things. Of course, there is no
right.
association with lentiglobus that has been associated. So either you
Yeah,
could be looking at a dual diagnosis here. So the first
yeah,
child you said did had a nephrolithiasis, right? There was something wrong with the kidney.
yeah. That's the
Uh,
youngest. Yeah, that's the one I
youngest.
saw for the first time. Yeah,
Yeah, so maybe he has this also, and along with that, an eye anomaly, which is the Peters along with the lentiglobus. The
right.
lentiglobus and lenticonus, although bilateral posterior lenticonus,
Yeah,
you think it could be genetic, but many of our patients also, we do not get a positive report in isolated bilateral posterior lenticonus. If it is anterior
okay.
lenticonus also, you think about Alport's, which is the most common
Yes,
association that you can, and in Alport
yes,
also you'll have kidney issues.
right.
So yeah, purely bilateral posterior lenticonus with in the absence of anterior lenticonus also has been reported, but with Alport's gene.
Okay, so okay.
Yeah, so
So
it could
a
be
whole
Alport's,
exome
but but
sequencing wouldn't
because
have.
your patient didn't get an Alport's gene, and Adams 9 and nephronophthisis is kind of correlating, which the
Yeah,
geneticist has to correlate with the systemic phenotype, whether it's correlating.
yeah.
Maybe the posterior lentigonal globus is a separate finding, and
But it's there
somehow,
in all the three kids, and
yeah.
two of the kids are Adams 9 positive. Like they have two of them, and one
Okay.
doesn't. The oldest one doesn't. The second and the third have Adams 9 positive homozygous, and
Mm-hmm.
but all three have the posterior lentiglobus.
And a posterior lentiglobus. Yeah, it's very rare to have
Yeah,
this familial type of
and
posterior
high
lentiglobus. Yeah.
hypermetropia. Like I had to.
With
Yes, that's
with
interesting.
lentiglobus, it's hypermetropia.
Yes, the axil length was so small, and
Oh.
I had to put like their the second child, who was around 3 years of age, has the highest of the hypermetropia, and the IOL power was something like 35 at 3 years of age. I mean, I think for him I put a 29.5 or something, and he's
Mm-hmm.
still wearing +9 glasses.
Okay. So maybe we are dealing with something like a posterior microphthalmos.
Mm-hmm.
Okay, and posterior
Okay.
microphthalmos with lenticular abnormalities. Many of our
Okay.
my microphthalmos patients do have lenticular abnormalities, in the sense that there is a anterior PHPV, and along with that the lens is kind of moved into the vitreous cavity. Okay, there's something called as an
Oh,
MPC syndrome, which is microphthalmos posterior lentiglobus. It is called. The entire lens is there. Then there is a PHPV and a coloboma. It's called MPPC. It's a
okay.
very rare thing I found in a couple of my patients. And there, the lens is really, and the eye is small, so that's why they'll be hypermetropic. And but the lens is kind of into the vitreous cavity. It's as if the PHPV, it has dragged the lens into the vitreous cavity.
Yeah,
And but
but I didn't find any PHPV.
yeah, so yours may be a variety, or maybe I'm just thinking.
And
And
very interesting. Yeah.
yeah, yeah. Please
Hmm.
go ahead.
No, you carry on. You carry
I
on.
was
Then
saying
I'll
that
tell
I
you.
was looking up for my patient also whether this MPPC has a genetic association. I think 4 or 5 cases have been reported worldwide, and none of them had a hit in the genetic testing. But yes, WGS has not been done in them. It's mostly exome testing.
Yeah,
So maybe WGS is
maybe.
the answer for these patients, because these are, abnormality in the eye development, and many a time
Right.
promoter genes which are there in the deep intronic regions may be
Hmm.
involved in kind of affecting or kind of regulating the master genes, other master regulatory genes, or master development genes. So
Right.
WGS may give you a better answer, so that could be the next step in your patients. If they're affording, like, you could get it done.
Yes, it's all free for them because they are Emirati patients.
Okay,
So
then go
when
ahead
I
with the
was up,
details. Great, and
yeah,
let
I
us
think
know what
yeah. So I will. And so when I was operating them, it was very interesting. So, obviously it looked like a posterior subcapsular cataract to start with. When I did an examination under anesthesia, then I could see a certain part was totally bulging out. And it
happened.
was literally as if the whole posterior capsule was
Posterior.
melting away as I was operating.
Uh,
Literally, like with the lenticonus, you will just have one blob, which
one
has
blob,
gone
yeah.
back, and
Mm-hmm.
it'll be like a natural posterior capsulorhexis.
Yeah,
This
it's a
one, like
localized
the
defect,
whole,
huh?
yeah, it was as if the whole PP was just melting away. It was uh, there was hardly anything. I had to place, except for one eye out of the six eyes, I had to place the lens. There was a three-piece lens in the sulcus for all of them. Only the first one, the 2-year-old, one eye had a lenticonus look, and I could put it in the bag. Rest of them all, but they're doing well otherwise. I mean,
Mm.
yeah,
Yeah,
it's
so
been
it's a very rare
more
thing.
than
I
a
would advise you to, get a whole genome, and if you get something which can solve other cases also, then please report it.
yeah. Okay, all right. And by the way, the other one who was also homozygous Adams 9 positive, like had a variant, he did not have any kidney involvement, and he's absolutely fine. The one
Mm.
who's the highest in the hypermetropia. So
Okay.
it's quite possible that the ophthalmic thing is something different, which we have not been able to find yet.
Yes. Yes. Quite possible.
Yeah. Thank you.
Okay. So, Nivedita, if there are no further questions, you're muted.
Yes, ma'am, we can end.
Okay. Thank you. Thank you, everyone, for joining. It was a lovely interaction discussion,
Thank
and looking
you.
forward to see you all in the next OGIG next month.
Thank
And if
you.
anybody wants to present in the next OGIG, most welcome. You could just need to mention in the group that you want to present some nice case or a concept. Uh, we can really accommodate and learn from you. Thank you so much.
Thank you, Dr. Shailja. It was a
Thanks,
nice
ma'am.
presentation.